Okay, so this talk today is on FHIR and Smart on FHIR and how it sparks innovation in healthcare. Just a quick bit about me. I'm an ex-medical doctor. I'm the chair of HL7 New Zealand and the co-chair of the FHIR Management Group. So I've been involved with FHIR pretty much from the beginning. I currently work as a product strategist for Orion Health, and I do blog quite extensively on FHIR at that blog, and I'm also an author of tooling which we use in the FHIR community, clinfhir.com. So today what I'm going to touch on is what is FHIR and why do we need it. I'll talk a little bit about what the FHIR standard actually is, touching on the resources, the exchange mechanisms we use, and most importantly profiling, or how we make FHIR meet your own needs. We will of course spend a bit of time on security and how SMART is going to enable this, and then I'm going to wrap up with how FHIR will benefit clinicians, healthcare executives and other parts of the community. And I'll then hand across to my colleague Paul, who will talk about what Orion Health is doing with FHIR. So I'm going to start off by just saying, well, why? Why do we have interoperability at all? And really there are three main reasons. Health information sharing really is becoming increasingly important. Individuals who are delivering care to patients, and indeed the patients themselves, expect all of the information that they need to deliver a quality care to be available at the point of care. But data is actually collected in multiple places, so realistically we need to move this information around from place to place, whether it's from point to point or from a place of collection to a central repository. And interfaces are expensive. Especially if you're not using standards, it can cost a lot of money and a lot of time to develop an interface between systems. So we need standards for interoperability. Of course, then begs the question of why FHIR? So just to take a step back, HL7 defines a number of interoperability standards, and many of them are in active use today. Version 2 is common, CDA is one that you may well be aware of. But back in 2011, the board of HL7 noted a number of things. They noted that the actual requirements for interoperability are increasing, partly due to a vast increase in the amount of data and the type of data that was coming onto the market. They saw genomics increasing, they saw devices and information from devices, they saw new requirements, analytics and population health. And then finally, they noted that implementers their expectations of a standard were becoming greater and greater. Implementers expect a modern standard that they can work with, and the existing standards in truth were a bit lacking, and so a fresh look was needed. And that fresh look was led by a very clever person called Graham Grieve, who is an Australian, but he has spent some time in New Zealand, so maybe that helps explain it. And Graham looked outside the healthcare community, and he looked at what other people were doing, in particular what other large systems were doing. And he came up with a system based on the concept of resources. So let's take a quick look at what FHIR actually is. So this is a bullet point. This is a elevator speech, if you like, for what FHIR is. First off, the name actually stands for Fast Healthcare Interoperability Resources. The fast being fast to implement and fast to develop. Healthcare because that's all we do. Interoperability because really we're focused on the exchange of information as we talked about before. And resources because that is a key component of FHIR. They are the small parts of FHIR that we exchange. FHIR consists of a consistent set of simple to use content models. These are the resources, and we will have a look at those in just a second. And most importantly, those resources can be extended in a controllable fashion. So we make the resources themselves as small as we possibly can, but we make it feasible to be extended to meet a particular business need. And this is a process of profiling that I'll touch on shortly. We support all the different paradigms of exchange, whether it's from a real-time API of a mobile device through to document exchange, such as a discharge summary or a progress note, messaging within and without a hospital, and more complex operations. These are all supported by FHIR. And FHIR has been designed with implementers in mind. Unlike some of the other standards that we've produced, FHIR, when we make a change to FHIR, we ask a question, is this going to make an implementer's life easier or harder? And it has to make them easier before it makes it into the standard. FHIR is freely available. You do not need to belong to HL7 International to use it, although there are many good reasons why you should do so. And it's available online in a detailed hyperlink specification. Now you might say, well, so what? You expect this sort of thing to happen. But any other standard these days, or in the past, has actually been distributed by documents. Now, if you go looking, for example, for the CDA spec, it can be quite hard to find. FHIR is just a Google away. FHIR has received very strong endorsement from a number of vendors and regulatory bodies around the world, including in New Zealand and HISO, but also in Australia, in Project Argonaut in the US, are all using FHIR. And finally, and perhaps most importantly, there is a massive supporting community behind FHIR. It is possible to ask a question online and to receive an answer to that question within minutes, which is something which is really quite special for FHIR. So these are some of the ways that we could be using FHIR. This is an example of using a shared EHR. So you can see that we have at the top of there, we have an EHR with shared information. To the left-hand side there, we have data coming in from a number of different sources. And then down the bottom, we have different consumers of that data using FHIR interfaces to access the information, both in the read-write. This is an important slide because what this does is shows how you can separate the source and the creators of the data from the consumers of that data. Provided that the interface remains unchanged, then changes can occur on either side without affecting the other. And this is an important part of enabling innovation. Here is just a picture of some of the information that you might put in such a repository. Clinical events that we want to share, such as encounters and prescriptions, lists of things like the patient's medication list. This is a big win for us if we were to get the my list of medications working correctly, for example. Then background information, the genomics, the social history, the family history, common functionality. Another key point we really don't have time to talk about, but FHIR gives us the opportunity to put complex business logic behind an easy-to-use interface, such as an immunization registry. And that can give us big benefits. And finally, of course, we need robust security and privacy. It's fairly well accepted, I think, that a shared EHR, such as I've been talking about, needs to be consumer, if not controlled, then consumer audited. Consumers need to know who is accessing their data, and they need to know what that data is. These are an important part of a modern EHR and something which FHIR facilitates. So let's just very quickly talk about the basics of FHIR. And I'm going to talk about three different parts. I'm going to talk about the content, which are the resources. I'm going to talk about exchanging those resources, and I'm going to talk about profiling. So here is a sample of some of the resources which exist in FHIR. These are some of the clinical ones. And generally, there's a couple of things I like to point out on this slide. The first is that when you look at the names of these resources, it's very obvious what they actually are. So a resource which is named procedure is pretty obviously about a procedure. And equally, if you are looking for a resource to do a particular thing, it's not that hard to find. If you wish to represent an immunization, for example, or an observation, again, they are resources that are there. This is all part of the ease of use. Developers and other implementers, and clinicians indeed, do not need to be deeply involved in the specification to understand what the bits actually mean. They can understand it at a high level. And this actually extends all the way through to the way in which we represent the resources on the wire. On the screen here I have an example of a patient resource. And you can see that the elements within that resource are logically named. You also see the three main parts of a resource. Up the top there we have the identity and the metadata about the resource. This is things like, where you can find it, when it was last updated, who by, and such like. Then we have the human readable summary. So we call this the lesson of CDA. So at the very least with the resource, you can put the human representation, what you expect the clinician to be able to read about that resource within the resource itself. Next we have the extensions, and you can see that the extension actually has got a URL, a pointer to the definition of that extension. So what that means is that if you get a resource and it has an extension that you don't recognize, it's very easy to find out what it actually means. And then finally down the bottom there you have the structured data that's been defined for this particular resource type. And as I've said, the philosophy that we have in FHIR is to keep that structured data as consistent and small as possible, and then use the extension mechanisms to make it fit different domains. And it's worth pointing out that FHIR supports both XML and JSON out of the box. Indeed, it's possible to create a resource in XML, save it on the server, and then get back in JSON. And this is because they're useful in different environments. Mobile in particular quite likes JSON. Another key part about FHIR is the ability to tell a story by referencing between resources. So you see here an example of a procedure in the middle of your screen. That procedure has as its subject the patient. It has down the bottom right-hand side there the performer, which is a practitioner. So what we do is we use the resources as if they were Lego blocks, and we connect them together to tell a particular clinical story. And here is an example of such a clinical story. So this is a fairly simple clinical scenario. It's a patient who attends, or a young boy who attends for a consultation complaining of a pain in the ear, elevated temperature, a diagnosis of otitis media is made, a prescription is generated, and then they return a couple of days later with an itchy skin rash, and an allergy to penicillin is diagnosed, and the antibiotic is changed. To the right-hand side there, you see colour-coded the different FHIR resources that can be used to tell this clinical story. And so what you do is you take the individual resources and you connect them together to form a web of information pretty much such as this. So what you can see is over to the left-hand side there, you have the individual encounter resources, and then you have the observation resources, condition resources, and so forth, which represent the clinical information that you've collected, and then finally linking across to the patient and the practitioner. Now, this is another important slide because what it shows is that you can collect information in a very granular fashion. Information which has been collected in this way can therefore be used for secondary purposes such as for decision support and for population-based analytics, of course, doing the proper privacy assessments, privacy rules as well. But what it shows is that natively FHIR allows us to collect structured information both for the purposes of delivery of health care, but also for the secondary purposes, which are becoming more and more important as time goes on. So that's resources. They're the major building blocks inside of FHIR. Well, the next part I'd like to touch on is the paradigms of exchange. Now, in the FHIR community, we actually think of 4 different paradigms, 4 different ways in which we share information. To the top left is what we call REST, or representational state transfer, if you really want the acronym. But this is really about real-time interaction with the FHIR server. The classic example of this is a mobile application. So that mobile application will make a query of a FHIR server. It will get information back, display it to the end user. The end user may update it, and they might send an update back in real time. So it's very much interacting in real time with the back-end system. To the right-hand side there, we have documents. And good examples of documents that we already have will be in the CDA space. Things like discharge summaries, referral letters, progress notes, and such like. Documents are a summary of care at a point in time, and they are intended to be kept pretty much indefinitely. Moving down to the left-hand side there, we have messages, and an example of that using existing standards is the HL7 version 2 messages. And the message is intended to do something, or to tell somebody to do something, or to notify them that something has been done. An example being when a patient's admitted into hospital, ADT messages are generated. Those ADT messages then inform the other systems within the hospital, such as a radiology system or a laboratory system, that the patient has been admitted and what their name and their other identifier information is, so that when an order comes to them, they know what to do. And once a message has been received and processed by its recipient, it can be discarded for other than audit purposes, as opposed, of course, to the document which was retained indefinitely. And then finally, the services. And these are really a specialization of the RESTful interface. What this allows us to do is to hide the complex logic behind a simple-to-use interface. And a good example of this is an immunization service. So one of the complexities that you come across, in a previous life I've been a PMS vendor, and one of the difficulties you have is when the immunization program changes, you then have a fairly complex set of procedures you need to do to catch your children up. Depending where your children are in the current program, the immunizations and vaccinations they need to receive can vary. Well, what you can do with FHIR is you can hide all of that behind a simple-to-use interface. And you simply pass the current immunization status of your child, their gender and age, date of birth to the service, and the service will then come back with the recommended or required immunizations. And you can imagine how that can give us a much more consistent experience and a higher quality experience. Of course, much simpler to update a single back-end service than it is to require a whole lot of practice management systems to update themselves simultaneously. So we get an increase in the quality of care that we can deliver. And the key part is that regardless of the paradigm that we use, the content that we are using, the resources, remain the same. So in this picture, you can imagine that we are receiving resources via a messaging system. Perhaps it's a laboratory result. We're getting RESTful type resources. Maybe it's a nurse on a ward entering data into a mobile device. They're being stored in a FHIR repository somewhere. And then when the patient is discharged, a document is created from those resources and sent out to the recipient. Now, today, if we try to do that, these are all coming in different standards. We need to map, convert, and otherwise change the data that we receive, which is not only time-consuming, but there's the ability for errors, programs, and quality loss. So by using the same resources for all of these paradigms, we achieve a higher quality, cheaper result. And the last thing I'm going to touch on in this FHIR, the basic session, is profiling. Profiling is actually really, really important, and if you only take one thing away from at least my part of the talk, then I would like it to be profiling. And it comes down to the fact that there are many different contexts in healthcare, but we want to use a single set of resources. So we want to use the same observation resource for a blood pressure done by a GP in their practice, done by the patient in their home, done in an ICU. So we need to be able to make it so that we can use the same simple, easy to use resource in all of those different contexts. In effect, we want to be able to describe how FHIR is to be used. We want to be able to author these in a structured manner and publish them in a repository so that they can be found and reused by others. And these statements can also be used as the basis for validation, for code, for reports. For example, the FHIR tool that I talked about earlier on just simply reads these resources and can generate a complete UI based on those resources. Now, not all applications will want to do that, but the capability is there if you need to do it. And there are really three main things that you do when you are profiling a resource. You may constrain it. You may say that there are existing elements in there that we are not going to use. You might say, well, I'm going to use a different set of code values, rather than the ones that are defined in the specification. And finally, and most commonly, you might want to add a new element. For example, in New Zealand, we have the concept of hapu and iwi against a patient. Now, we will create extensions that represent those. So what profiling does is profiling adapts FHIR for use in specific scenarios. And here is an example of profiling that you could actually do. So this is a patient resource. So at the left-hand side there, you can see that the specification actually says that you can have more than one name. Well, what we could do in our profile, or what Australia could do in a profile, is to say that there is only one name for a patient and it must exist. It's required instead of optional. Across to the top right-hand side there, you could say that the Medicare number is a required identifier for this resource. Moving down the right-hand side, we could say that we don't support photos. We could add an extension if we wanted to represent the ethnicity inside of the resource. And then finally, to the lower left-hand side there is we could change the value set, if you like, or the options that exist for marital status if they are different in Australia or New Zealand from what the specification actually does. So this is what profiling is all about. Profiling is about taking the core set of resources and making them work in your scenario. So I'm now going to leave the resources behind, and I'm just going to touch on SMART and talk about security and how we can get an ecosystem out of these things. So just to talk about SMART it starts a couple of things. Technically it's a profile, which is a bit of an overloaded word, on OAuth 2, which defines sort of authentication mechanisms that can be used, because security is not a core part of FHIR. And there's a very good reason for that. And that is that security itself is a highly specialized domain. And security is managed in different ways in different environments. So what we do in FHIR is we say that, look, you've got to use a secure system. We have some recommendations that we make in FHIR, but we do not mandate how security should be done. We do provide a number of hooks within the specification. There are tags that you can apply to a resource, for example, to indicate how sensitive it is. There are specific resources that are available. The audit event resource can be used to track access to notes. The provenance resource can be used to indicate who actually supplied the resource and so forth. And as you can see down the bottom there are a set of recommendations that are present in the specification. So what SMART does conceptually is to wrap a layer of security around each individual participant. So this is a bit of a high-level picture, of course, but it shows how the individual parts of an ecosystem are protected by means of a secure interface, by being able to authenticate using the SMART derivations of OAuth 2, using SSL across the wire, and so forth. So what that allows us to do is that allows us to build up the ecosystem, where if we think about what an ecosystem actually is, it's where we have a number of different suppliers of information and services that can be used interchangeably by consumers down the bottom there. So in that picture, you see across the top in that arc there, you see the various parts that can exist inside of our ecosystem. We have the repository to the left-hand side, which is where the data is stored. We have conformance, which is where all of our profiling information is stored. Terminology, a key part that we really don't have time to give justice to. This is where your SNOMED, your LOANC would sit. Decision support, workflows, services directory, provider registries and authorization. These are all core parts that are needed to create a secure ecosystem upon which we can do innovative and neat things. And FHIR is across all of these things. FHIR provides the layer that allows the consumer at the bottom to access those services. So just moving away from technology for a second, let's think about what are some of the benefits that that this capability gives us. And I'm going to start out by benefits to implementers and vendors. So the first thing is that an implementer or a vendor gets to use tooling and technologies with which they are already familiar. The XML and the JSON, they're using HTTP, REST. So this is something which in previous standards wasn't the case. If you want to use version 2, you have to understand how version 2 actually works. With FHIR, that's much less so. With FHIR, we have predefined resources and we have predefined APIs, predefined ways of accessing the information and representing the information, which means that an implementer can spend their time focusing on the core application functionality rather than figuring out how its infrastructural stuff should work. Extensive documentation, samples and reference server implementations. So again, developers love samples. Every single resource in FHIR has got multiple samples, and those samples are cross-checked. We have a build process which ensures that all of the samples are accurate and correct when they go up. We offer validation services. I've talked about the active and supportive community. There are source code libraries available with both Java and .NET, but also in other languages such as PHP and Swift. There's even a JavaScript one out there. These are all things that a developer can pick up and use and make it easier to develop the functionality that they want to develop. It's mobile friendly. Indeed, FHIR already grew out of a need to support mobile type technologies. We're seeing a very large number of mobile apps being developed, particularly in the smart space actually. Smart develops mobile applications quite a lot. So overall, what FHIR does for an implementer or a vendor is it increases the commercial viability of app development, because you can develop an app and be confident that it will work against more than one source of data, which means that we're going to get a much richer source of applications being developed within our overall system. What's in it for a clinician? Well, the main thing I think for a clinician is that it allows them to get involved in the system design. As hopefully you saw through some of the earlier slides, this stuff is actually not that difficult to get your head around. The details certainly are, but at a high level, it's not that hard for a clinician to understand what a resource is and what profiling is, and to help participate in developing systems that meet their particular needs. It's going to give them an improved access to more complete information because it's easier to shift around, and we're going to start seeing some of the more complex stuff like genomics becoming available. So there are already FHIR resources and profiles for genomics. The genomics subgroup is quite active in FHIR. So as this becomes more and more mainstream, FHIR is ready to use it. And all of this is going to create foster an increased choice of applications that are available to clinicians, particularly in the mobile space. So rather than having to use a single application that's designed so that it's good enough for every clinician, you can imagine that there will be specialist applications for, say, a GP, for a rheumatologist, for an orthopedic surgeon, and so forth. And those applications will look at the same set of information, but they will present the information which that specialty needs. Clinicians will benefit from increased development speed, which means that their business problems will be solved more quickly, and that comment about decision support. It's been well recognized that as the amount and quality of data we collect becomes more complex, there's a greater and greater need for having better decision support available to the clinician. This is front and center with what FHIR is trying to do. And all of this will result effectively in saving time for the clinician. What about a consumer? Well, the consumer can look forward to the prospect of having more and more applications which allow them to participate in their own care. Again, because it makes it easier for people who are not deeply versed in the healthcare system to write applications which can nevertheless securely access that data. And that's, of course, both because of the nature of FHIR itself and the fact that SMART is there to provide best practice for authentication and security. That in turn means that the patients are going to be able to engage more deeply in their own healthcare. And they will also benefit indirectly by the fact that the clinician who is treating them and who is making clinical decisions has got access to a more complete record. Indeed, patients expect this to happen. Patients are expecting, patients actually believe that this happens today. And quite often they say, well, you know, really? Does my clinician not have access? Does the doctor I'm seeing in the ED not have my GP notes? So FHIR is going to help make this actually happen, and it's going to improve the quality of care that we can deliver. Overall, what we are going to see is an improved patient experience. We're going to see reduction in wasted time, and we're going to see an increase in the quality of care that we can deliver. What about to a healthcare organisation, such as a hospital? Well, internationally, pretty much every vendor of significance is committed to FHIR. And so what we should see is we should see faster deployments because the interfaces become standardized. Faster deployments and standardized interfaces means that we're going to have a lower cost for interoperability overall. And the other thing that's going to happen, which is maybe not quite so good for vendors, but we're going to see reduced vendor lock-in because as FHIR is adopted by source systems, to some extent, actually, whether you want to or not, you're going to have to adopt FHIR, then it's going to be easier for a healthcare organisation to move from one system to another because they will not have data locked behind proprietary interfaces. We also see, or we also expect, and indeed are seeing in some areas, certainly in New Zealand, where some organisations have got their own development shops. And because the data in their core systems is being exposed by FHIR-type interfaces, those small development shops are able to develop customised applications to meet the specific needs of that healthcare organisation. And finally, from a healthcare organisation perspective, by capturing the data, which is in a structured format, it makes it easier for them to manage their population and to perform the more advanced analytics on that population, something which is becoming more and more important as time goes on. So overall, summarising what I believe the benefits are to the sector in FHIR. So FHIR is an evolving next generation standard. And I do need to say FHIR is an evolving standard. We are not yet done. We are at what we call a standard for trial use, which means we believe that the standard is good enough to be used, and indeed it is being used. We have plenty of production installations internationally, but we are still flexible enough to modify it to meet implemented needs. FHIR is focused on decreasing interoperability costs and unlocking technical innovation, making it easier for people to do neat, cool, innovative things on top of existing data. Profiling is used for customizing FHIR for your organization. SMART is a key part of enabling security for FHIR. So in summary, FHIR is going to bring benefits to clinicians, to healthcare executives, to implementers, and most importantly, FHIR is going to bring benefit to patients, those patients or consumers who wish to involve themselves in their care. So at this point, I'm going to hand across to my colleague, Paul Bazin, who will talk a little bit about what Orion Health is doing with FHIR.
Thanks, David. That was a really good overview. So just as a brief introduction to myself, my name is Paul Bazin. I'm the Product Director for our Amadeus platform here at Orion Health. I've got 20 years of experience in health IT, worked in hospital settings, in public health and regional integrations, but effectively focused on healthcare integration for the last 20 years. Been heavily involved in our product range in terms of the R&D teams at Orion Health and involved in a number of our products. And really we're starting to use the FHIR capabilities so much in our products here that I'll take you through some of what we're doing. A little bit of a brief introduction for those who don't really know much about Orion Health. We were founded in '93 in New Zealand. We're dedicated entirely to healthcare. You can see there the range of offices we have around the world. So we've got 2 offices here in New Zealand, including our main development centre, and we've got 3 offices over in Australia, with one development centre over there. We've cut our teeth on healthcare integration. We introduced some of the world's early world-leading HL7 tools in the 90s. We now use that integration knowledge to provide tools focused on complete patient records and value-based care. And as you can imagine, we have our offices all around the world because we have clients all around the world, and so there's a kind of geographical representation of where our clients sit. All 20 DHBs in New Zealand use our software, and we've got significant expansion and growth in the United States, Australia, UK, and many other areas there. So that's a brief touch on the company. We have a range of solutions that either provide FHIR or use FHIR as part of their capabilities. For simplicity here, we've broken this into 4 main categories, and we'll go into a bit of detail on the 2 at the top there that have those little FHIR logos with them. The first item there is the integration engine. So this is Rhapsody, and Rhapsody is really focused on data exchange between systems, with the main task being to map between formats and standards. Traditionally, this has been based around HL7 version 2, but now Rhapsody comes with a set of tools for mapping between HL7 and FHIR resources as well. Our next product over there, which is labelled the Precision Medicine Platform, is our Amadeus platform. This harnesses Rhapsody's capabilities in there, but effectively our Amadeus platform is about building a complete patient record from numerous sources, normalising that data and making it useful for either analytics or for applications to make use of via APIs. And we're building an ecosystem of third parties around our Precision Medicine platform to make sure that information is useful and available to all. And I'm sure you can guess how FHIR is playing into that story. We'll talk a little bit more about the FHIR capabilities of those 2 products in a minute, but I just want to touch on our other 2 product ranges. So built on top of the Amadeus platform is our Population Health Management Suite, and we also have a set of applications for hospital settings. The Population Health Management Suite helps identify patients at risk, then helps the care team across all of the different care settings focus on keeping that individual well and effectively out of the acute settings. This includes setting and tracking individual care plans, tracking goals over time, and a full medication management suite. Our software for hospitals, besides the integration engine, of course, really helps administrators and clinicians manage their patients more effectively. This includes a PAS problem list and medication management components, collaborative work lists, and diagnostic orders. So there's quite a range there, and those population health management and hospital software systems are built on top of our Amadeus Precision Medicine platform and utilize those FHIR-based APIs today in terms of accessing the data. Before we dive too much into the products themselves and what we do with FHIR, I'd just like to take a brief commentary on some of the evolution of healthcare integration and where we see some of the standards being used. As we're all aware, the healthcare industry doesn't change overnight, and in reality, most people are going to have to deal with a range of these standards at various points in time. So HL7 v2 we still see as the standard for in-hospital information exchange. It's going to be around for a long time. There's a large investment in that technology. We'll still be mapping OBX segments for years to come. So HL7 v2 is not going to be replaced overnight with FHIR APIs. CDA is a completely different paradigm, being document-based. And I think one of the key things around CDA is the lowest common denominator capability that you get for those who don't really have strong electronic systems. So the human readability of the CDA there means that CDA is likely to be around for a while in terms of certain use cases as well. And then, of course, we have FHIR. Now, the thing that FHIR really brings to this is the ability to access discrete data elements of information in real time, so rather than being an event-based paradigm. So this is especially useful for mobile applications where an application may only need access to a patient's medication list, but not really be interested in all of the other information around an event. And with a general trend towards mobile technology, FHIR provides a great mix between simplicity, granularity, and some of the security aspects that David also talked about before as well. And this will be equally valuable in both the hospital settings, where HL7 v2 is dominant, and also in the community, we see more of the CDA today. whether it's tablets on a ward round or whether you've got a patient engagement apps, FHIR is going to have applicability in both these domains that we see the other standards here. And so really the key thing that I think we all need to be aware of here when we look at the FHIR and how to move and migrate to FHIR is that we're going to need tools that are excellent at all of these standards to make them interoperate. It's not going to be a one or either. It's going to be a mix of different standards and technologies in the marketplace for a while to come. And so I want to show you how Orion Health products can help solve some of these problems with this interoperability. So Rhapsody, we've talked a little bit about already as the integration engine. You can think of this as the data hub for an organization. Rhapsody's job is to make sure that data from one system can be formatted and understood by other systems in the network. It's got an awesome drag and drop interface that provides fast development and powerful mapping capabilities between all these multiple formats. So over the last couple of years, we've been working at how we integrate FHIR support into the engine in a way that's flexible and easy to use. So we've got now better support for REST-based services. We've got the ability to map JSON structures to and from HL7v2. And this really helps an organization to use the same set of tools for their standards-based messaging and also their FHIR messaging as systems evolve that use that technology. And I think the gradual integration of FHIR APIs to coexist with the existing HL7v2 based infrastructure in particular, it's really critical to gain the benefits of the API integration while harnessing an existing infrastructure and investment in your existing systems. So there are two main use cases for Rhapsody's FHIR capabilities. The first is to use Rhapsody to FHIR enable existing systems. In this way, Rhapsody can expose a FHIR interface and translate JSON requests or XML into a query supported by existing systems. So if you've got, for instance, a provider directory that you can access via HL7 messaging today, you can put Rhapsody in front of that and provide a FHIR interface that other FHIR-enabled systems can use. So that enables you to make use of existing infrastructure without having to replace everything at once. And that's kind of going to be key as we see the rollout of FHIR through the environments. The second use case is where there's a gap in the data inside messages, such as the missing provider name. And this is pretty common in terms of integrations that we deal with on a day-to-day basis. And Rhapsody provides the easy tools to call a FHIR API and turn that provider ID into a provider name given a FHIR provider service. In this case, the use of FHIR over another messaging standard is likely to be lighter weight than other messaging standards and faster to develop. So that's really a benefit there. So what Rhapsody provides you with is a flexible mapping system that enables FHIR interfaces to exist with, or to integrate with existing non-FHIR systems. We then move on to our Amadeus precision medicine platform. Amadeus makes considerable use of the FHIR APIs. What we try to do with Amadeus is to create a complete patient record from all sources and make that information available to users in a standards-based method. We had three key pillars when we were looking at creating this new platform. One was to solve real-world integration challenges. So that might be out-of-sequence messages or missing data. And we've built an infrastructure and a framework around new technology that really harnesses the 15 years of integration experience that we've had and focuses on solving those real-world problems. The second is to scale to support new data types. So when we look at healthcare today, we see the need to integrate a lot of new data types that sit outside of healthcare, traditional healthcare, that is. So we need to bring in, if you look at the determinants of health, we need to bring in the social, behavioural, and even environmental factors that don't sit inside today's healthcare systems. And when you think about some of the device data that from the mobile devices that David talked about, and even bringing in genomic information, today's systems really aren't designed to handle that volume of data. So we've built a system that's designed to scale to bring in all of these new types of data into one platform. And then the other thing we've really focused on is how do we accelerate innovation? So healthcare is an industry that really needs to look at its commercial models or funding models and find a way to innovate keep people healthier faster. So we really want to accelerate that innovation. And here's where the FHIR APIs can come in. We're taking all that data and exposing that up in a unified, standardized way to other organizations and other healthcare applications. What this means for application developers is a standard-based method for getting information into the Orion Health system and other FHIR compliant systems, I should point out there. So when we look at the Amadeus ecosystem, we've got three main areas that we focus on. One is the actual APIs. So Orion Health, as part of our platform, has standardized on FHIR APIs where they're available. And that's a growing set, I think. One of the things that David mentioned was that it's very much evolving, but it's actually going quite fast in terms of new areas. So there are FHIR APIs being evolved for claims-based data, for genomic information, and all sorts of areas out there. So it is evolving very quickly. Then we need to look at the API management, and the API management layer typically provides you with your authentication, so secure access across the platform, who should be accessing what APIs, and how do you make sure that they're throttled and some applications don't affect the performance of other applications. So that API management layer gives you that important ability to handle SLAs. And then we have the third-party ecosystem there, and this is really about helping organizations innovate and get going faster with FHIR APIs and with our Amadeus platform. So we have a sandbox that's available for people to come and utilize to build applications using those FHIR APIs. And then once they've built their applications using our sandbox with dummy data, they'll be able to come to us, certify the applications, and then we'll be able to look at distributing those. And some of those will use the Smart on FHIR interfaces that David talked about, and some of them will use just kind of traditional FHIR and Orion Health APIs there. And when we build an innovation ecosystem there, it's really interesting to see how quickly new ideas and ways to use the information come up pretty quickly. For instance, we're working with some early adopters at the moment who actually writes software for restaurants, and they use beacons in their store to recognize when a VIP walks in. So someone's got the application on their phone, and they walk into the restaurant, and the wait staff are notified that this VIP has just come in and these are their preferences. And we're looking to integrate that information with our Amadeus platform so that we can actually share food allergies with that wait staff automatically. And if you start thinking about this, this is really going to, these kind of other uses of healthcare information are really going to enhance engagement and bring health into the everyday world. So it's really going to accelerate innovation. Obviously, a lot of issues to work through in terms of access to that data and consent and all of those kind of things. But it really does show the ability to innovate quickly and really change the way that healthcare is delivered today. So what do we think of FHIR? So we think that FHIR has the potential to unlock siloed data across the healthcare community. We think it can drive innovation. We think it's going to drive real patient engagement. We think it can make the right information available to the right authorized users at the right time. FHIR probably won't replace HL7 version 2 completely, so you need to think about the tools that you'll make to make the most of your existing investment, but also provide for the new capabilities enabled by FHIR, because it is coming and it's going to come quickly.